Uh, so what to do once the surgeon has removed all the visible tumor? So liquid biopsy in general can be used in multiple settings in colorectal cancer. Okay, even when we are normal individuals, we can check your blood and see whether there is any tumor DNA. That test can be used as a screening modality. And now we have Guardant Shield approved in US, where we can pick up in normal individuals whether you have colon cancer or not. Then on the right, we have, what if you have already developed colon cancer, you don't have tissue, you want to study the molecular profiling, you take a liquid biopsy and study the DNA from the blood. What we want to talk is the center part, where the tumor was there, the surgeon has removed the tumor, and now you want to check the blood and see the DNA levels and see whether there is any cancer cell moving around which might be responsible for relapses later. So actually this concept came almost 7-8 years back when an Australian professor, Jeannie Tai, she saw a remarkable thing in a small subset of patients, 30 patients, of colon cancer with liver metastasis when they underwent operation, and then they did a blood test with ctDNA. Patients who had ctDNA positive were on the purple curve. Nobody survived at the end of 3 years. Patients who had ctDNA negative were all on the blue curve. 85% survived at the end of 3 years. Remarkable, right? So no right colon, no left colon, no 1 met, no 2 met. Just a simple blood test which could prognosticate colorectal liver metastasis in such a strong way. So this test single-handedly became the most prognostic marker for stage 4 colorectal cancer back then. And since then, multiple investigators wanted to try this. That after a surgeon operates the colon, if you do the blood test and if the test is positive, you are on the bottom curve. If the test is negative, you are on the top curve. So multiple investigators, the French, the Germans, the Koreans, and you name it, and everybody, and even the Americans with Professor Kasi. So can we use this information to de-escalate somebody? So if I know their blood test is negative and the patient is going to be on the top curve, can I get away by not giving them unnecessary chemotherapy, right? And operation alone is good enough. So that was the question we wanted to ask. And the reason we want to ask is, if you see stage 2 cancer, even NCCN is confused. Okay, all options are okay. Observation is okay, FIFU is okay, K-pox or FOLFOX is okay. So who decides what to do? Okay, a physician has to take a call that which treatment he has to or she has to do. And the thing is, in stage 2 colon cancer, giving chemotherapy versus not giving chemotherapy, the absolute benefit is just for 2 months. Absolute benefit is just 2 months. So then the question comes, can we avoid chemotherapy in some patients? And to answer that question, again, Professor Jeannie Tai did the study called Dynamic, where half patients were treated based on physician's discretion. You know, physician decided whether to give chemo or not in stage 2 colon cancer, and other half got chemo only if the blood test was positive. If blood test was negative, no chemo was given. Okay? And the end point was, how many patients had recurrences at the end of 2 years? By not giving chemo, you know, by relying on a blood test, are we making it inferior? That was the question. And long answer short, no, you are not. So as long as the test was negative, the survival was identical, 93% in both arms. And in doing that, the number of patients who required chemotherapy were half. So that means if tomorrow you treat 100 colon cancer patients, stage 2, and you decide to give 50 patients chemotherapy based on your judgment, but if you use ctDNA, you might still give the same result, but end up giving treatment to only 25. That is, you halve the number of patients who end up getting chemotherapy. So definitely very less neuropathy. Of course, there were critiques, there were questions on Twitter and all, that what about the T4 tumors? You know, T4N0, are you going to leave chemotherapy? Are you comfortable not giving chemotherapy? So then the dynamic came with a subset analysis of their own study and showed outcomes were identical to T3N0 versus T4N0. A similar study was also performed in rectal cancer cohort, that whether to give chemotherapy after neoadjuvant chemoradiation and surgery or not, and the same phenomenon was found. If the test was negative, there was no difference whether you give chemo or you do not give chemo in rectal cancer. And people who ended up getting chemotherapy were halved, okay, were halved, 46% versus 76%. Now, so this was again from Australia. One can argue that, okay, this is just one center. What about the other center? There was another center in US, Pashtun Qazi from Cornell. Now he's in City of Hope. They designed a bespoke study. What they showed, again, the same phenomenon. You'll see this recurring phenomenon. In stage 2, if the test is positive, you are on the red curve. If the test is negative, you are on the blue curve. And you see the blue curve is as flat as anyone can think of, right? The survival is more than 95%. Now, so they did a study with a questionnaire, okay? They gave a questionnaire to the physicians who were prescribing this test. And they asked, by doing this test, did it change your treatment? Did it change your treatment? And only 15% said, yes, we changed our treatment. 85% of them said, we did not change our treatment. We did what we wanted to do, okay? But amongst those 85% of patients who did not change the treatment, the second question was, okay, the decision that you were going to make, did you become confident after seeing the test that, I'm doing the right decision? And in that, 84% said, yes, the decision that we were going to make, we made it with far more confidence because of the test versus not. And in patients who actually changed the treatment, what was the change? Half of them de-escalated and half of them escalated treatment based on that. So this was an observational study. This was not an interventional study, okay? Now, again, if you see the ctDNA positive versus negative, stage 2, 2-year survival, 45 months. If you tell this to anyone, they'll think of that we are talking of pancreatic cancer, okay? Normally, stage 2, we want to talk everything 85 plus. While in stage 3, we talk about 60, 65%, but if ctDNA is negative, we talk about 87% survival. So you see how this test clearly gives us prognostic significance that who does well and who does not. Now, important is they did this experiment that in case where ctDNA was negative and you gave chemotherapy versus you did not give chemotherapy, was there any difference? Pakka in stage 3, if you give chemo, that is better than not giving chemo in stage 3. But the graph is on your right. You know, the blue curve and the red curve. Can you spot the difference? Can you put a light in that? No? Okay, I'll just zoom in. Okay, we just zoomed in. You cannot put even a LED light between that. That is how the close it is. 89.7 versus 89.5 months survival in case, whether it's stage 2 or stage 3, whether you give chemo or not, this is the survival. So clearly, this is going towards de-escalating strategy. And if you see on the left, the benefit of chemo was restricted to patients who had actually ctDNA positive. They are the ones who were driving all the benefit. A similar test was also found on another platform. Mind you, all the ctDNA the tests that we've been doing or we've been talking so far are tissue-based. That means you need the colon resected specimen. You do NGS on that and then make the probes for that patient, for that particular patient. This is the test which does not require tissue. It's tissue agnostic. So it's plasma only. So you can do it whenever you want. So this gives us the added advantage of being rapid. So you decide today, you get the result in 10 days. So that is Guardant based. The other one is Signetra or Natera based. Even that assay showed the same phenomenon of being highly prognostic. So to answer the question 1, can we de-escalate in colon cancer if ctDNA based MRD is negative? For me, in stage 2, answer is definitely yes, and I'll show the real world experience as well. Now, on the flip side, if you do the test and the test comes positive, then doing the same FOLFOX or CAPOX, does it make sense, or do you want to go up? Okay, so that was the question Pegasus trial asked. Okay. Now, in that, again, it was a small trial, 135 patients, out of which 35 patients came positive. Okay, 35 patients came positive ctDNA after the surgery. So they got 3 months of CAPOX. Okay, standard 3 months of CAPOX. In that, 11 patients became negative. So CAPOX did its job about 30-35% of the time. CAPOX or oxaliplatin doublet does its job, and the ctDNA was negative. But the mistake they did was, then they said, okay, now oxaliplatin we can remove. You know, we'll just give capecitabine because we want to avoid neuropathy. That was a problem, because that's when the recurrences started coming back. So when you have a ctDNA positive, that is not the case you ever de-escalate. That's lesson number 1. You never de-escalate if your ctDNA was positive ever in the patient's journey. Now, remember, 23 patients did not convert to negative. The ctDNA positive, after 3 months, the test was again positive. What to do? Remember, if test is positive, risk of relapse is 100%. Okay, you are on the blue curve. Remember the curve down. Nobody survives. So you can tell the patient that according to the guideline, we will wait for you to have a relapse and you'll die because I cannot save you then. Or do something innovative in terms of giving FOLFIRI in an adjuvant setting. Okay, you want to up your systemic treatment and see if you can save them and change the ctDNA positive to negative. And actually this trial showed that amongst these 24 patients, 11 patients they could convert back to ctDNA negative, okay, because of FOLFIRI. And so far as we speak today, none of these 11 patients have relapsed. Remember, they were destined to relapse. A ctDNA positive at the end of your treatment means 100% relapse rate. That means the cancer is still there in your body. But seroconverting them back to negative, about 40% of the time, you could make a difference. So yes, escalation in patients who are still ctDNA positive or MRD positive at the end of treatment is a reasonable approach for some patients. So this was the poster that we presented. I presented this month, earlier this month, in fact last week at ESMO GI. And to see in detail, we tested 63 patients of colon cancer. 27 were stage 2, 23 were stage 3, and 12 were stage 4. They all underwent operation, all underwent curative surgery, and after 4 to 6 weeks, the blood test was done. Okay? After 4 to 6 weeks of surgery, the blood test was done. In that, you could see in stage 2, only 7%, only 2 patients had a blood test positive. That means out of 27, only 2 patients had positive. 25 was negative. Same for stage 3, out of 23, 9 were positive. And out of stage 4, 12, 6 were positive. So 50% was positive. Okay, so this was the baseline characteristics, that how we saw in these patients. Now let's see what happened to them. Okay, now remember I said there were 25 people who had stage 2 cancer and the test was negative. Okay, what do you think would be their relapse rate? And the median follow-up was 339 days, so let's say 1 year. Okay, we've just been collecting those data. So the median follow-up is 1 year. I agree it is little short. We want a 2-year data. But at the end of 1 year of these patients, how many have relapsed? Answer is 1. 1 in 25 have relapsed so far. So that is 4%. 96% of patients who are ctDNA negative in stage 2 cancer have not relapsed. Okay, this is as good as we do oncotype DX in breast cancer, right? Getting up to the 95% mark. While in stage 3, the confidence was not that much. You see, in stage 3, we have a longer duration. It's 2-year follow-up. Okay? Well, I'll tell you a story about this. 6 out of 15 patients relapsed despite having a negative test. That is not comforting. You know, out of 15 patients who were negative test, 6 of them relapsed. That is not comforting. But the thing is, because I was one of the first ones to do this test back in 2022, the platform used by these companies during that time in 22-23 was far inferior compared to the platform used in 24-25. You know, their sensitivity over these 3 years have gone up tremendously up. So what you see is that the stage 2s were collected more or less in 24-25, while the stage 3s and the stage 4, we started doing it in 22 and 23. And that's why you're seeing the sensitivity dropping to just 60% or 65%. And the same thing with stage 4. Out of 6 patients who were negative, 2 of them relapsed. They were not supposed to relapse, right? It was a negative test. So now, interestingly, the question was asked to me that patients who relapse despite a negative test, where do they relapse? Where are they relapsing? And if you see 9 patients relapsed despite having a negative test out of 46, 8 of them were either in lung or peritoneum. Only 1 was in the liver. And this is the same thing what we see with other investigators, especially dynamic. If you see on the left is patients who relapse despite having a negative test. Remember, peritoneum and lung are called the Achilles heel of this MRD. That means if the metastasis is going there, your test is not good enough. Means your test is not going to pick them up. So I think so this Indian data gives more comfort, real world data, that yes, at least in stage 2 with a sensitivity of 95%, we can all start using MRD in routine clinical practice. So to conclude, ctDNA is one of the most powerful prognostic marker for recurrence for colorectal cancer. We can't throw every resected colon cancer patient under the chemotherapy bus, that if you are colon cancer, you have to take Capox or Folfox. ctDNA based approach to select patients for adjuvant chemotherapy is very promising. Role of ctDNA in selecting patients for escalation and surveillance seems even more promising. Remember, never de-escalate any patient who had ctDNA positive ever in their journey. So this is a strict no. And the main problem for these tests so far, there are at least 20 companies pursuing to master how to develop this test better and better. The two main problem is, if the metastasis is going to happen in peritoneum and lung, the test falters. So I say they are the Achilles heel for this test, and hence it represents a great opportunity for the companies to improvise this test. Yeah, with that, thank you so much.